Yeah. So first, thank you for the invitation, for the nice introduction. Thank you especially Federico for organizing all that. And I will not thank you for choosing the worst picture of me you found on the internet. Yeah, I think until now you talked mainly about the therapeutic use of psychedelics. My talk will be rather about the recreative use of psychedelics. And there is usually some sort of fear in the public that that's again a bad drug, especially psilocybin. If we liberalize too much, there will be the same problems we had with cannabis, with heroin, and so on. And there are good reasons to misuse those substances. I try to show you, I'm sure you are already convinced, but I'll try to show you that is not the case if we talk about use motives. At first, psilocybin is not an addictive drug. That today we know. It does not induce automatized behaviors, not in animals, probably not in humans. There is no loss of control for the initiation and the termination of a use session. That's already good news. But we have those same data also for benzodiazepines. So, for example, Valium and those medical drugs, which are not either addictive. There is no increased automatization in behavior. There is even a reduction on the benzodiazepine of the dopamine release. So they should be anti-addictive. And unfortunately, we experience large and wide misuse also of those substances. So the question is, are there other arguments against this misuse power of psilocybin? Psilocybin, the use motives we have clearly to separate two situations. One situation is the therapeutic use. There, clearly the use motive or the motivation will be a suffering and a demand to reduce the suffering. That's clear. So we could call that, and we will call it a coping motive. And then there is the recreational use. And among the recreational use, we can find several types, several classes of motives, of reasons to use. Coping is surely part of that. And I will show you that the coping motive is a rather problematic motive when it comes to the use of cannabis and alcohol, and probably also of other drugs. So the question will be, is this also a main use motive for psilocybin? And I'll show you at the end the data of a small study we realized, and the results will be, you see. So we start with what we call the motivational model. There are alternative models for explaining addictive behavior. For example, the model of automatized behavior, where the addictive person doesn't make any decisions, it comes automatically. The smoker smokes and remarks afterwards that he has smoked his cigarette. That's the automatized model, automatism model, and here is the motivational model. The motivational model starts from assumes that a person makes decision about whether or not to use substances, even if the person is addicted. It remains always something like a decision, something like weighting the pros and cons of consumption versus the pros and cons of abstinence. And the decision is always a combination of emotional and rational processes. The rational processes are still there. That's the idea. And the decision is made on the expectations of the effect of the consumption, be it the effect of the product itself, in this case the drug, or the effects it will have on maybe on the context. So there is always a decision. Why ask about use motives? Because therapeutically, if we know use motives and if we are able to detect problematic use motives, we could intervene in regard to prevention and to therapy. So it is also said it's one of the most proximal predictors of quantity and frequency of use. So when I'm making a decision, I am evaluating my motives, and then I'm deciding and using. So that means it's the most proximal. And the literature now is rather rich and has shown that there are, in fact, specific use motives which are correlated, associated to specific use patterns. And targeting, right, those motifs may be useful in reducing problematic use. I will show you mainly the literature which has been done around alcohol, and some has been done with cannabis. I try to resume all this literature. So what is a motive? A motive is a psychological state, can be understood psychologically, that moves the person to engage. So that's also the center of the procedure on an organized means a target-directed set of behaviors that maximizes the fulfillment of the motive. If I have a motive, I will want to fulfill it. If I want to have pleasure consuming, pleasure has to be fulfilled. That's the idea. Easy. It's usually not directly observable. We can ask for it. We can do studies asking people, why do you use this drug in this situation? And that's what we have done. Might be inferred from behavior, for example, coping behaviors. A person that is anxious and then drinks alcohol and seems to be less anxious. Motives may be conscious and unconscious, may become conscious afterwards, what is often the case, for example, for cigarettes. Most smokers know afterwards why they have smoked a cigarette. When they are beginning to smoke them, they aren't aware of it. There are approach and avoidance motives, approach to have an effect, avoidance to have less of an effect. The difference, you'll see, is important. Use motives may largely depend from what we call personality traits. So characteristics which persist over time, which may be sensation seeking. Sensation seeking means really living for strong sensations. For example, a normal sensation seeker could be a risky skier, could drive rapidly on the autoroute, and so on. Impulsivity, clearly negative mood, depression, mood lability, like in borderline personality disorders. And there are clearly also environmental factors, family tradition, peer pressure, cultural tradition, and so on and so on. As several authors have tried to classify those motives, and the most frequently used classification classifies according to main dimensions, and the questionnaires, most of the questionnaires which have been developed use those 2 dimensions. First, the source, the chain. Trying to change mood by addressing or an internal state or an external situation. There we have again the slide from before. Or the valence, the direction of mood change, or to increase positive mood, or to reduce negative mood. Positive mood, it's clear, enjoyment, euphoria, negative mood, anxiety, depression, and so on. So with these 2 dimensions, we can define 4 classes, 4 categories of motives. At first, social motives, externally conditioned and with the idea to increase positive mood. Having good time with friend, being sociable, so drinking together with friend at the Café des Amis, for example. We have conformity, still externally influenced. To reduce a negative mood, here we have mainly peer pressure. To use a drug to be part of things because there is a pressure to be part of it. It's not the same than social. So clearly to separate. The initial hypothesis before doing all the studies was that peer pressure was the worst of motives. With peer pressure, you induce addiction. I will show you that's not the case. It's even on the contrary. Then there is enhancement. To have the effect of the substance, be it alcohol, cannabis, to increase positive mood and as an internal source. And finally, coping. To reduce a suffering, an internal suffering, forget problems, help when depressed, reduce anxiety in social situations, etc. Starting from this classification, mainly one instrument has been developed and has been used now for more than 20 years. And that's the Drinking Motives Questionnaire, the MQ. The Drinking Motives Questionnaire is clearly the most widely used. Is lately almost the only used instrument, originally developed for college students. There have been now also some studies in elderly, middle-aged and elderly patients. The factor structure is rather stable, so it's a really well validated instrument. In its first version, were included items for enhancement, so voilà, to improve the positive mood state, coping, and for social motives, and working on the subject a little bit later, conformity had been added to the questionnaire. The current version is a 20 items questionnaire, rapid to fill out in 5 minutes time. It's done. It's really easy. On the basis of the results of the drinking motive questionnaire was developed the marijuana motives measure. Very few little differences, more linguistic than with regard to the content. Adapted from the drinking motives questionnaire. 5 motives. A 5th motive was added, and there I already have to admit, in our first study we forgot the 5th measure, the 5th dimension, which would have been rather interesting, but for the next waves we have already included them. 5 motives, like for alcohol: enhancement, social, coping, conformity, and expansion. It's the 5th motive, which would have been probably the most interesting in itself, but comparing it with alcohol and cannabis, you will see the 4 already existing motives were enough. So expansion means using the drug to be more creative, to open mind finally. Yeah, here the review of the results of alcohol, of the alcohol studies. Enhancement in a whole series of studies was always associated with increased drinking. Increased drinking means more frequent and more increased quantity, and even increased quantity per session. So we should expect, as we usually do when drinking increases, more problems. But when controlled for increased drinking, the problems in practically all studies disappeared. So it's correlated to increased consumption, which is self-evident. If I use a drug for pleasure and it provides me pleasure, I'm motivated to use it again. That's rational. That's intelligent. Coping. For coping, it's different. We also have seen an increased use of alcohol, and this time also an increased prevalence of alcohol-related problems, which still persisted if one controlled for heavy drinking. So alcohol use problems, even if there is not much alcohol. So really problems, if there are problems in alcohol users, that's what we can conclude. They search coping motives. There is already a problem. Social was rather correlated to moderate drinking. So drinking in company, for the pleasure to be in company, seems to be rather a protective factor than a risk factor. Less excessively drinking and less alcohol-related problem. There is a protective factor. Conformity, what at the beginning was thought to be the worst risk factor, again showed rather reduced drinking. And there is a hypothesis is for those who drink because in order to be accepted by a group will not necessarily drink when they are outside of the group. So that could be the protecting factor. What's more, and that's will not be a great surprise neither, is when participants to studies indicated more reasons, more items they rated high, then the risk for heavy drinking increased. So when you have many motivations also over different categories, the risk will increase. Different categories. I remind you that in some minutes. Motives change over time. That also has been found. Adolescents and adults for alcohol and for cannabis do not show the same consumption motives. With increasing age, conformity goes down. It's clear peer pressure doesn't have the same importance. And coping motives increase. Bad news for you, with age, problems increase too. So, first conclusions for alcohol. Avoidance motives, so to reduce something which is not pleasurable, coping, associated with more maladaptive drinking than approach motives. Drinking for pleasure, approach motives. And the idea is to avoid, especially avoiding drinking alcohol means at the same time not trying to resolve the problems one has. More externally sourced motives, social conformity, seem even to be protective. Cannabis, it's the same. It's the same, more or less the same figures. Enhancement related to increased use, but this time also with more cannabis use problems in case there is an increased use, and coping again the worst risk factor. Social negatively, conformity negatively, and expansion associated with cannabis frequency. We can have the same reflection as with enhancement, and that time also with cannabis related problems. There are prospective data for cannabis. Positive reinforcement use, these were associated with increased cannabis use, also later on. Negative reinforcement motives predicted cannabis-related problems. So also longitudinally, more or less the same result. And expansion motives in adolescents, when they are trying to widen their view as adolescents, it's done. As adults, they don't need it anymore. That's my interpretation. Would be a nice interpretation, I think. And coping motives, again, bad news. So, our study. An online study, French, with 6 months duration online. We collected fully responded questionnaires of 109 respondents. We assessed them by an adaptation of the Drinking Motives Questionnaire again. using psilocybin. We use the mystical experience questionnaire, the assist to screen for other substances. I will not show these results, and attitudes to drug use. I can already tell you the attitudes to drug use were rather liberal. This is the sample, mostly males. Age, we had some over 50, which I think is a nice result. But most were younger respondents. And country of response, a little bit from everywhere, but mostly from Switzerland and France, some from Belgium, Canada, and some also from South America. Psilocybin everywhere. Here, the result, or the descriptive result of the mystical experience questionnaire. What may be interesting? You have for transcendence in time and space, a rather Gaussian curve for mystical effects also, but for ineffability, I never read it for you. And positive mood that goes. Clear response with high rating. If there is a clear effect specific, that the profile is that one and positive mood. So here the results for the Motives questionnaire. That's completely different from what we see for alcohol. First, enhancement, mainly high motives for enhancement, but it's distributed, but mainly for enhancement. Almost nothing for conformity. A little bit, but not really high rated for social, and coping even less. So there we have already one response. If coping is the worst predictor, the worst risk factor for misuse, we shouldn't expect too much misuse. That's already on. And here, just the review of all the studies we found for alcohol, for marijuana. Oh la la, what happens there? Cannabis effect. And psilocybin normalized, the data always normalized, and you see real profiles, and the psilocybin profile clearly distinct from at least those two other substances. For alcohol, at most social, a little bit social, but not really. It's enhancement. It's clearly enhancement. Coping, no. Conformity, no. Psilocybin is not like cannabis. Should not be discussed like cannabis. Is not in the same class with regard to motives. Those may be partially the same people, but probably aren't. They can be separated mainly with regard to motives. So, psilocybin motives almost exclusively enhancement motives. They use it because there is some pleasure. And again, using something because it provides pleasure is rational. It's not irrational. Practically no coping motives. No psilocybin-associated problems to be expected we haven't seen them really. Compared to alcohol and cannabis, clearly less social motives and almost no conformity motives. And these are again, psilocybin is not like addictive drugs. If you want to help us to increase our databases, we have launched now several other waves. One for MDMA in French. We will also launch it in other languages, in English, hopefully soon. We have for LSD, still in French, psilocybin Italian. We have also a Polish version, but yesterday evening I didn't find it anymore. So there is one, a Spanish version we already have, and psilocybin in German. Make photos. I know you don't use any, but tell your friend who you have used last year to fill out the questionnaire. And I thank you for your attention. I'm ready for almost all questions.
Hi. Up here. Here.
Here.
Yeah. Just a question about your the definition of your dimensions, specifically with regards to cannabis, but also psilocybin. And you mentioned that you neglected to include expansion in your polling. What is the distinction between expansion and enhancement?
Yeah.
And then secondly, where would the medicinal use fall under? Would that fall under coping, or was that not regarded?
This was not regarded, but hopefully into coping.
Right.
But where would be the problem to have a treatment which is also pleasurable? So
right.
would be one of the first. With regard of expansion and enhancement, enhancement is to feel the effect of a substance, to increase mood, to be euphoric, to have a pleasurable time. That's the items typically for enhancement. Expansion is to see the world differently, to have another view of events. So it's clearly mind open. Expansion is mind opening, and that was already the case for cannabis.
Right. Okay.
Does it respond to your question?
Yes.
Okay.
Yeah. Yeah. I mean, I think you could probably bucket expansion and enhancement, to be honest. As you did, I think you probably put them in the same bucket.
Yeah.
Expansion and enhancement.
That can.
But then you're also looking at this in the context of misuse.
Yes.
And not use.
Yes.
Right. Okay. Thank you.
And I have a question here regarding Iboga. A speaker earlier mentioned that Iboga looks really promising for treatment of addiction. Do you have a comment on that?
Yeah.
And would you be interested in researching it?
Yes and no for the two questions. Yes, there is some interest. There have been studies for withdrawal, opiate withdrawal. Clearly, yes, it seems to reduce withdrawal symptoms. But withdrawal is not to confuse with addiction. So a completed withdrawal doesn't mean that addiction isn't there anymore. So. But there are beginning, especially preclinical studies showing that there can be some interest. No, I'm not really currently interested in ibogaine because the side effects are clearly limiting its large use in clinics. And until now, the research was mainly on opiates. have been others, the studies for alcohol and so on, but for opiates it's the most clear. And we have alternatives. I don't know if I should say that, but we are planning a study with LSD in opiate-dependent patients who are already under heroin treatment. So it would be, if we are able to do it, heroin treatment, so giving heroin to patients and LSD. Yeah.
Hello, here.
Yeah.
How would you define the expansion properties of alcohol, for example? You said that you didn't include it.
No. Expansion was never included.
Yeah, but in case you would include it.
Yeah, it could have. Nice question. It could have some expansion effects among anxious persons. Anxious persons which have a rather close view just on their problems. And one of the ideas of psychotherapy is to open vision, to find new ways of thinking, to seeing things, to respond. And that's, in that sense, acutely, it could have some expansion effect. I'm not sure I would give alcohol with that idea.
But for example, there is the social abilities that are expanded in theory already.
Yeah.
No?
Let's think about a study to do it. I'm not sure.
Okay.
Yeah, I also have a question just next to her. Speaking from experience, I think, I know psilocybin is a bit harder to get compared to alcohol or marijuana, like on the black market. And I think this has a huge impact on the reasons for taking it, because it's a higher effort to get it. So did you think about this and how it can limit the implications of the studies?
Then there would also be a larger difference between alcohol and cannabis, because cannabis is in the illegal market. But no, we didn't think about that. No.
Yeah, I think it's way easier to get cannabis than psilocybin.
Yeah. Not here in the region.
Fair enough.
I don't tell you where the spots are.
Okay.
Hi, I have a question. There was a slide where you shared the use motives of cannabis, alcohol, and psilocybin.
Yeah.
And the curve was exactly the same for cannabis and psilocybin.
Yeah.
With the conformity being lowest, yeah.
Yes.
And the enhancement being highest. It's remarkably similar, although the level is a bit lower, whereas your conclusion was they are very different.
Yeah, because here we are really low, and here we are already in the middle. You see, there is clearly a motive which may play a role, but that's almost nothing. Let me show again. What was it? Coping. That's everything. Not really much. And the Likert scale goes from 1 to 4 for each item, 5 items. So you see that it's really almost nothing. But yes, you're right. For enhancement, for both drugs, enhancement was the main motive. And for alcohol, so it was was social. So clearly a difference between alcohol, and maybe there you're right. The market isn't the same. Clearly, enhancement, the main reason. Coping remains a main reason also for cannabis and isn't for psilocybin. And I think this difference probably will be, or I hope so, explains why psilocybin hasn't the same problematic effects than. We'll see with LSD. If we have the same curve with LSD, you have to agree with me.
Okay, thank you.
So fill out the questionnaires or tell your friends.
If I try, yeah.
Here. Thank you for your presentation. You presented psilocybin as like the motives of use, but I was wondering, how do you see, or how can you explain the use of psilocybin as a treatment for addiction? Understood my question? No.
Yeah, I can give you an answer, but I'm not sure it's the right one. I can explain it because we have studies that show that it's effective. And we can propose it to patients with a clear indication, but I'm not sure that's the answer you're searching for.
It was more on how can you explain that taking psilocybin will help people with addiction to get out of their addiction?
Yeah. Addiction, like depression or like anxiety disorder, is a disorder, behavioral and cognitive disorder characterized by a reduced variety of behavior and cognitions. And the idea there is to induce plasticity, neuroplasticity, but also psychological plasticity to go elsewhere with thinking, with behavior. Addiction treatment, finally, is nothing else than to learn to behave differently, to open the spectrum of behavior we have at our disposal. And the idea there is to just open this spectrum. That's and probably it's also that way that finally all our treatment work when they work.
Hi, I have a question. So this is a hypothesis, but I'm going to venture that the current psychedelic-assisted therapy, so psychedelic being studied for treatment and the popularization of all that might increase, at least especially in my own personal experience in private practice, the use of the psychedelics with the motive of coping. They learn that, oh, this could potentially help me. So how do you think that could interact with, like, what could that look like then with the psychedelics like psilocybin, for example?
Yeah, I'm not so sure about that, because we should have seen that also for cannabis. And for cannabis, we have this situation since more than 20 years, because cannabis is used. We have 20 years advance with cannabis, and the data didn't change over the years for cannabis. So coping, you have seen all those points. It's more or less the same. So if we extrapolate from the cannabis data, I wouldn't expect much more coping motives that could become problematic.
Mm-hmm. Okay, thank you.
I'm not sure that just taking psilocybin in a self-care mode will have the same effect than in a therapeutic context. Preparation, all that means much.
Mm-hmm.
Mm-hmm. If I can just bounce back on the question that just got asked, there's an interesting distinction to make between passive and active coping. So passive coping is the sort of normalization of what's happening in your life. You take some cannabis, take some alcohol, and soldier on. But it seems to me, and I think most people here would agree, that psychedelics promote an active form of coping, where you take them and then suddenly the next day you think, well, why am I doing this? So there's kind of a different mechanism, I think, there. Maybe it would be worth making that coping distinction further, like more granular.
I will.
Hi. Hi.
Ah.
Thank you. Thank you for the presentation. And so I'm wondering about microdosing. So from your point of view, will microdosing be has a prospect to be a kind of treatment for enhancement or for coping, for anxiety, because so far as we talked today, yesterday, I mean, on the sessions, like the use of psychedelics are on group use, on cure kind of session. It's not on you prescribe like anxiolytics and you take it at home without any guidance. Just read the notice. So, from your point of view, do microdosing of psilocybin or LSD or MDMA?
Yeah. 1 year ago, I would have told you, microdosing, no, why? No, there is no effect. It's placebo. But the last data, we have also some data for preliminary data for addiction show that there could be some effect. And probably not everything is in the experience itself. There may be some pharmacological effect that doesn't need the high doses or the medium-high doses. I think preclinical studies could probably help us better than clinical studies for the moment to progress on this axis. In any case, these are interesting substances, also pharmacologically, not only for psychologically. Ask me again next year.
Absolutely, thank you.
Okay, I think that's it. Thank you very much again.